Ladies and gentlemen, welcome to the Cleveland Clinic Community Healthcare Forum. Please welcome CEO and President, Dr. Toby Cosgrove.
Well, good evening. I want to welcome you all and thank you for coming for what I think is a very important discussion of a very important issue. This is the second in our community healthcare forums. And what we wanted to do is bring issues to the greater public in Cleveland about healthcare that we thought were important for the dialogue. And as you can tell tonight, we're going to focus on the opiate addiction. And I have two great experts here with me that I'd like to welcome to the stage. If you gentlemen would please join me. The Surgeon General, Dr. Vivek Murthy. Nice to have you here. And Chuck, thank you very much for joining us today. I'm delighted to have you here. Why don't you gentlemen have a seat? And there is an extensive curriculum for them. And Dr. Murthy is served as the 19th Surgeon General of the United States and was nominated as Surgeon General by President Barack Obama. He was confirmed by the United States Senate in December 2014. In November of 2016, Dr. Murthy's office released a 400-page report, Facing Addiction in America. This landmark document is the most comprehensive survey of addiction that's ever done. It redefined addiction as a chronic disease and provided evidence-based overview of potential treatments. Please welcome Dr. Murthy. Chuck Rosenberg is the acting administrator of the Drug Enforcement Agency. His agency leads enforcement of the Controlled Substances Act and has primary responsibility for drug investigations at home and abroad. Part of the United States Department of Justice, it has more than 4,500 special agents, and its aviation division has over 100 aircraft. Most recently, he was Chief of Staff and Senior Counsel to the Director of the FBI. He was appointed as Acting Administrator of the DEA in May of 2015. Please welcome Chuck Rosenberg. I'd like to just share with you a little bit of data about the situation that we're talking about tonight. First of all, the leading causes of death in the United States are shown here. And if you look at number 4 accidents and number 10 suicides, both of these are affected by the opiate addiction. During the Vietnam War, there were 58,000 deaths during the entire war. And last year, there were 52,000 deaths in the United States from drug overdose. And essentially, we have a war going on in our country on an annual basis. The cost of this is about $55 billion in health and social costs and $20 billion in emergency department and inpatient care. And if you look at where the drug overdose death rate is the most important, the dark blue areas represent those, and here we are in Ohio as being one of those areas that is heavily affected by this epidemic. If you look at the synthetic opiate deaths, Ohio leads the way in the country. And in Northeast Ohio, we have a tremendous increase in this. 2016, an increase of 192%, over 2 deaths a day in Cuyahoga County. And if you look at how it's affected the Cleveland Clinic emergency room, we see about 2,300 opiate-related visits and about 1,200 overdoses in a year's time. One of the good things that's happened is we're beginning to see across the state increasingly physicians recognize the potential for problems with overdose prescriptions, with prescriptions leading to addiction. And they're fighting me here. And so what we are seeing is a marked reduction in the number of opiates dispensed across the state. Now, I'd like to bring this home to you in terms of the human capital and the human suffering that is involved. This is a news story that appeared on the nightly news about a family here in Northeast Ohio.
In the farmland of rural Ohio, the last year has harvested a crushing sadness, the longest road Roger Weinmiller has ever endured.
You just stand there helpless and just watch it happen. There's nothing you can do.
Last March, his 31-year-old daughter Heather visited him. She excused herself and shut the door.
It was about 10:05 at night. She reduced right here in my bathroom.
Right here?
Yeah. I'm the one that found her.
His loss, sadly, is growing more common, especially in Ohio, where a new CDC report shows an average of 9 people died from a drug overdose every day in 2015. A number the Weinmillers know all too well. 5 days before Christmas, Roger and his son, Roger T., would suffer another loss. Gene Weinmiller was just 37 when he died, also from a heroin overdose.
My brother's my best friend. And I think between him and all the stuff with my sister hit and my brother at the same time, and it's like being punched in the gut by a heavyweight boxer. And knowing that I was still addicted and still wanted to get high made me sick to my stomach.
That's right. Roger T. is addicted to heroin, too. How difficult is day-to-day life as an addict?
I can't put it into words.
But his brothers and sisters' deaths have motivated him to allow his father to drive him to outpatient rehab. Doses of Suboxone ease his cravings. Counseling tries to ease his pain.
I look forward to the future for the first time in a long time.
They're now on the road to recovery together.
I pray that you're my success story.
For so many families like theirs, the stakes could not be higher as heroin hits home. Gabe Gutierrez, NBC News, Blanchester, Ohio.
Well, let me ask both of you. This is the worst drug crisis we've had in American history. And what's caused this? Chuck?
Many things. One thing I think about often is our addiction to pain medication. We are the world's largest consumer of pain pills, and there's a relationship, both causative and correlative, between addiction to pain pills and addiction to heroin. Not to throw too many numbers at you, but 4 out of 5 heroin users started as addicted to pain medication. That's a stunning figure, and that's a big part of the problem.
Yeah, you know, we got here on a path that was paved with good intentions. You know, a few decades ago, doctors and nurses and other health professionals were urged to treat pain more aggressively. They were told that they were under-treating pain. In many cases, we actually were. And in some cases, for certain populations, including minority populations, we still are. But that urging was not accompanied by the training and tools that clinicians often needed to treat pain safely and effectively. And it coincided with aggressive marketing of opioid medications by pharmaceutical companies, which in some cases really underplayed the risk of opioids. That, combined with a lack of treatment resources and a very unfortunate stigma around addiction, which prevents people from coming forward and asking for help. And together, we got to where we are today, where we have since 1999 seen a near quadrupling in the quantity of opioids prescribed, and more than a quadrupling in the number of overdose deaths from opioids, but all without a significant change in the amount of pain that's reported by Americans.
You know, one of the things that's happened here that is generally unrecognized is the fact that we now have 2 new things entering into the drug armamentarium, fentanyl and carfentanil. And fentanyl is 50 to 100 times more potent than morphine. And carfentanil is what's used to put elephants to sleep. And, you know, Chuck, where did this come from?
Well, let me tell you the equation I use. heroin times 50 equals fentanyl, and fentanyl times about 100 equals carfentanil. And that ought to scare the hell out of us. Where it literally comes from is China. Heroin has to be harvested, cultivated, and shipped north, primarily from Mexico. With fentanyl and carfentanil, you mix it in the lab. The profit margin is immeasurably higher with fentanyl and carfentanil, and it's much simpler to make. And so we are seeing it now in many iterations all over the country, laced into heroin, replacing heroin entirely, laced into cocaine as counterfeit prescription medication. It's killing people, sometimes on the first encounter. It also worries me, if you don't mind me adding this, it worries me how our law enforcement officers encounter it, how they interact with it. There was just a story out of East Liverpool, Ohio, about an officer who had some residue on his shirt and brushed it with his hand, and more likely carfentanil than fentanyl. And it took 4 injections of naloxone to help save his life. So this stuff can kill you to the touch.
So just so you're not familiar with it, Narcan is the antidote to these drugs. And to have 4 shots of it shows you how potent the carfentanil is. Have you run across this much across the country, the carfentanil?
So I've gone to some places which have run into trouble with carfentanil, but more so places that are struggling with fentanyl. And as Chuck mentioned, there's a significant amount of the supply that is coming from China. And I remember sitting, in fact, here in Ohio with a group of law enforcement officers and public health leaders who were struggling to figure out how to deal with the fentanyl issue because the ease of access through the internet was just absolutely scary. And there hadn't been measures that had been taken yet that were stemming the flow of fentanyl into our country. So it's a real challenge because the big problem with fentanyl is most of the time people don't know that they're actually getting it. It's laced in, as Chuck mentioned, with other products. So someone might think that, okay, they're just taking heroin or they're taking something else that they know the potency of, and their body may be used to that, and they may have built up a tolerance to that level of opioids. But when they get overwhelmed with a medication that's 50 to 100 times more potent, that can rapidly depress their respiratory system, and then they are much higher risk for overdose deaths. And that's the struggle that we're having right now.
So Chuck, the DEA, what have you done to try and keep this flow of the drugs from China out of the country?
Well, a bunch of different things, some successfully, some less so. We think about the problem in 3 different ways. One is the traditional enforcement that the DEA does, along with our partners, like ICE and the FBI, aiming as high up on the supply chain as we possibly can. I often describe it like this, Toby. There's an unholy alliance in America between violent street gangs and the primarily Mexican cartels that supply them. We have to aim at that point and work our way up. The second thing we do, we are also a regulatory agency, and so we work with registrants, doctors, distributors, manufacturers, folks in the chain of supply to make sure there's no leakage out of the legitimate stream of commerce. And third, and this may surprise you, perhaps surprising coming from the head of the DEA, but I think we have to do a much, much better job at demand reduction. First off, I think about addiction solely as a disease. It's a public health crisis and it's a disease. And we have to change the culture. We have to educate, we have to treat, we have to rehabilitate. Because if we don't change the culture, then we don't break the cycle. And if we don't break the cycle, this poison continues to flow into the United States and kill our folks.
Well, you talked about addiction being a chronic disease, which is really a different way to begin to look at this problem.
That's right. And I want to underscore the importance of what Chuck just said, that this is a chronic disease that requires a public health solution. 10 or 15 years ago, you may not have heard that from someone who was leading the DEA or leading law enforcement agencies. Unfortunately, 20, 30, 40 years ago, we took a different approach to dealing with the drug crisis in America. We began a war on drugs that sadly became a war on the people who use drugs. And we have to be very careful that we don't slide back into that approach and that we keep pushing the idea that this is in fact a public health crisis. It requires a public health solution. But the point that Toby mentioned about addiction being a chronic disease is an important one to mention, because far too many people that I encountered when I traveled the country as Surgeon General, far too many of them looked at addiction really as a disease of purely choice. They looked at it as evidence of a character flaw or a moral failing. They didn't recognize that this is in fact a disease of the brain that has been well demonstrated by science. We know that addiction changes the circuitry in your brain, in your prefrontal cortex, in your basal ganglia, in your extended amygdala, and it affects the parts of your brain that control decision-making, that govern how you deal with impulses and how you handle stress. Now, if I were to ask how many people here have ever tried to get on a new diet plan or an exercise plan, my guess is it would be the majority of folks in this room. And if I were to follow up and ask how many of you fell off the wagon at some point, I won't ask you to show your hands, I don't want to embarrass anyone, but I will say that I myself have fallen off the wagon at times with exercise and diet plans. And I want you to imagine just how much harder it would be to stick to that diet or exercise plan if the very part of your brain that enabled you to do so was in fact compromised. And that's the struggle that someone with addiction deals with each and every day. When we start to recognize that addiction is in fact a chronic disease of the brain, then we could treat it the way we treat diabetes or heart disease, as a medical problem that deserves the same care, the same compassion, and the same urgent attention that those illnesses do.
Let's talk about the recidivism rate, because once you get addicted and people even go into in-house rehabilitation, the recidivism rate is still substantial.
The recidivism rate is high, but it actually depends what you compare it to. So there's often an idea out there that treatment for addiction is stick somebody in a rehab for 2 weeks and then they come out cured. My hope is that at the end of this session that all of us will recognize that that is not in fact how you treat addiction. And if that is the approach you take, then relapse rates are incredibly high. But it turns out that if you really want to treat addiction, you have to treat it the way you would think about diabetes or high blood pressure. It often requires medication, although not always, but sometimes requires medication, like medication-assisted treatment with the use of methadone or buprenorphine or naltrexone. It requires counseling services, and it requires social support. And with a combination of those for a prolonged period of time is what will actually enable you to have the best outcomes. Does that mean the relapse rates are zero? No. But the relapse rates with evidence-based treatment become comparable to the relapse that you see with other chronic illnesses like diabetes. So that's essential to know. I do want to emphasize, though, the last piece of that, which is the importance of support and community support in particular. There is not a single person I have met, or of all the people that I encountered with addiction across the country, who did not have somebody or some group that enabled them to go through the long tunnel of addiction and come out on the other side into recovery. Everyone needs someone, and community becomes an incredibly important part of staying in recovery and avoiding relapse. And that's why, as we think about how we overcome this crisis, I always tell people you don't necessarily need a medical degree or a nursing degree in order to help address addiction in America. All you need is a heart full of compassion and a desire to address addiction. And you can provide the support that people need. That's an essential part of the recovery process. And in doing so, you can often save people's lives.
Let me go back a minute to you, Chuck. What success have you had, and what are in beginning to stop the smuggling and how it gets in? I mean, obviously you have aircraft and for surveillance and lots of other techniques. Is there something that you found that's really successful and others that aren't?
Yes.
Do you want to share them with us, or is that a secret?
I can share it broadly speaking. And at the risk of sounding somewhat trite, our greatest successes occur through partnerships. So the DEA only has about 4,600 special agents. That makes our special agent cadre about 1/3 the size of the FBI, and the FBI in turn is about 1/3 the size of the New York City Police Department. So we're relatively small. So are they, but we're relatively smaller. And so we find ourselves, Toby, working very closely with our state and local partners. We have about 2,700 task force officers embedded with the DEA around the country. Task force officers like the Cleveland Police Department, like the Cleveland Clinic Police Department at one point, sit with us, work with us, struggle with us to try and get a handle on this. That is, again, at the risk of sounding trite, probably the most important thing we do. Then, on top of that, if we're doing our work right, given our limited resources, we are trying to hit that sweet spot, that unholy alliance between the cartels and the street gangs and go up. We can't go down. Here's why. We don't have the time, the resources, or the inclination to do small things. And in any event, as I mentioned earlier, and I completely agree with Vivek, the users form a part of the public health crisis, not a law enforcement crisis. We also have international partnerships, and I'd be remiss if I didn't mention that. The DEA has the biggest international footprint of any federal law enforcement agency. We're in 92 cities in 70 countries abroad.
Really?
Places you might not expect to find us and places you would wholly expect to find us. We're in China, which is incredibly important to our work, and soon I hope to be the first federal law enforcement agency to open a second office in Guangzhou, or in Beijing. Believe it or not, we are now exchanging leads and information with our Chinese counterparts, something that would have been unheard of just a few years ago. And the Chinese, and I want to give credit where credit is due, despite the fact that they are the source for so much of the poison flowing across our borders, has scheduled at our request certain synthetic drugs, including certain fentanyl compounds, to try and ban the export from their country to ours. So it's partnerships. And when we get it right, it works.
Let's just shift for a second, if we could, to physicians. And then let's start with institutions. What can institutions like the Cleveland Clinic do to help with this particular problem?
Well, there's a lot that institutions can do, and in fact, this is not a problem that government can solve alone. It really does require individuals, community organizations, and institutions like the Cleveland Clinic to lead. There are a number of things that are important, though. Number one, working to help change prescribing practices so that we are treating pain safely and effectively is incredibly important. I mentioned that we urge doctors to be aggressive about treating pain without giving them the skills and the tools. And now we have to fill that gap. We have to train our providers in how to recognize and assess and treat pain safely, but we have to give them the tools to do so as well. Many of you may be familiar with prescription drug monitoring programs, which are present in nearly every state in America right now.
Why don't you explain a little bit to the audience about that?
Sure. Prescription drug monitoring programs are essentially tools which allow you as a clinician to understand what other prescriptions you, the patient in front of you, may have been getting. So, for example, if you're about to write a prescription for oxycodone, but you check your prescription drug monitoring program and find out that multiple prescriptions have been filled in the last couple of weeks for that very same medication, that should raise a red flag for you, or in that case, many red flags for you. And without a prescription drug monitoring program, though, you may not know that because medical records are often, as you know, not connected to each other. So these are very useful. The challenge we have, though, is they're not quite perfect yet. Many of the systems are not fully up to date in terms of their data. They're not real time. They have a delay. In some cases, in many cases, they're not integrated with the electronic medical record, which makes it logistically harder for clinicians to use them. And sometimes they also very often, they don't have data from beyond one's individual state. So if you are living in a part of a state which is close to the border with other states, I live in Washington, D.C., for example, and you can be in Maryland or Virginia in a matter of 15 minutes. So in those circumstances, you need systems that cross state lines. So what institutions can do to be helpful is to really to provide the training and the tools to clinicians. They can also make it clear to clinicians what treatment resources are available so that a clinician knows where to direct a patient when they need help. But perhaps one of the most important roles that institutions can play is as advocates. We know that an institution can't set up a prescription drug monitoring program for the entire state on its own. We know that they can't fund the expansion of treatment centers across an entire state on its own. But institutions like the Cleveland Clinic have a very loud voice and a large megaphone. And that voice can be used to advocate for the changes that our community needs. They can be used to ask our legislators to put dollars toward prevention and training and treatment so that we are spending our money where it's most important, and so especially when it comes to prevention, because that's an area where we significantly underinvest.
Yeah. Chuck? So one answer to your question is this. Doing things like this, as Vivek said, is unbelievably important if we're going to change the culture. I wanted to make 3 quick points. There are things that everybody sitting here can do if they're inclined to do it. One is, with the FBI, the DEA put out a movie entitled Chasing the Dragon, which you can find on YouTube or at DEA.gov or FBI.gov. Watch it, and then watch it with your kids or your nieces and nephews. Or show it in a school, and then have a panel discussion afterwards. It's a horrifying documentary, but it's spot on. Second, the DEA runs a national take-back program. Twice a year, anonymously and safely, you can clean out your medicine cabinet. We just did one at the end of April. I hope some of you participated. We had 5,500 sites around the country. We partnered with 4,200 state and local law enforcement agencies. And here's the cool number. We took in 900,000 pounds of stuff. Right?
How much?
Thank you for asking me to repeat it. 900,000 pounds. Because most heroin users start on pills, and most pill addicts get their pills from someone who got it legitimately. Cleaning out your medicine cabinet is unbelievably important. And third, we recently partnered with Discovery Education, another big voice, to create a STEM-based curricula free to middle and high school teachers, students, and parents, available at operationprevention.com. It teaches, in a way I could never do, but the two of you could, the science of opioid addiction. And any school can download it and put it right in their curriculum for free. If we're going to change the culture, those are 3 ways to think about it.
You know, I'm glad you mentioned that, Vivek. You know, there are a lot of parents here, and what are the signs that you should begin to look for if you think your child might be using drugs?
Well, it's a great question, and I think that parents have an incredibly difficult task, especially in 2017, given all the challenges and threats that kids face when it comes to health, including addiction. There's a lot to keep track of. There's a lot to manage. I think about this as a new father. I have an 8-month-old son at home, and
I don't think you have to worry about it just yet.
Well, so it's interesting you bring this up because we don't have to worry about it right now. But most people think that kids get into trouble like in high school, when they're older. This stuff starts a lot earlier than we think. And when you look, in fact, at the programs that are effective at preventing serious drug use among kids, they're often programs that are instituted in elementary school. Mm-hmm. So as a parent, when you're thinking about what to look out for, one thing I want you to keep in mind is to be vigilant because you may not see anything. And it increases the importance of prevention, of taking action to talk to your kids early about drugs, making sure that you do expose them to educational resources like what Chuck mentioned, but make sure that they have access to others, whether they're teachers or whether they're doctors, people who can talk to them about drugs and what they actually do and why they may be dangerous. But it also raises the importance of focusing on social and emotional well-being for our children, because there's a strong connection between stress and the use of alcohol and illicit drugs. Many people who have been struggling with addiction have told me that it was at stressful moments in their life that they relapsed. And they turned to drugs because they didn't have healthy ways of dealing with stress. Again, if you look at the programs that have been most effective in schools, they're not programs that teach kids all the do's and don'ts about drugs. They're not programs like the DARE program, which I went through when I was young. Instead, they're actually programs that focus on how to strengthen resilience among children, about how to enable them to deal with conflict and adversity, how to manage stress in their lives, how to build healthy and productive relationships. So these are important. And if you are able to help your children develop strong social and emotional skills, you will be doing a lot toward helping them achieve not just a healthier life free of addiction, but also increase their chances of graduating from school, of doing well, like in the workplace afterward. If your child does run into trouble, though, some of the things you might see is you might see behavior that's more erratic. You might notice that they are perhaps not always honest or straightforward with you about where they're going. You might notice changes in their behavioral patterns in terms of more volatility, in terms of their emotions and their behavior. The challenge with trying to look for signs is that the signs can be incredibly diverse. And what they sometimes you may see a divergence from the traditional patterns in your child, but sometimes you won't. And that's why being proactive in discussing these issues with your children, talking to their teachers, to their school administrators to make sure that they are monitoring your children, this becomes all the more important.
Toby, first of all, congratulations on the birth of your child.
Thank you.
That's awesome. It's also, you're right, it's frightening because it's harder and harder with every passing year. But when you said that he doesn't have to worry, it made me think of a statistic that's horrifying. 1 out of every 200 children are now born in the United States with symptoms of opiate withdrawal.
I don't know that everybody understood that exactly, so tell them what that means.
Well, another way of stating it, every 25 minutes, a child is born in the United States whose mother was addicted to opioids, and that child is suffering to some degree from the same symptoms of withdrawal that the mother is suffering from. Vivek's right. We have to find ways to have really difficult conversations with people we love. It's a hard thing to do. And we have to find ways to take complicated concepts and break them down into pieces that are digestible and understandable. I'll give you an example. You used a statistic at the beginning that in 2015 we lost 52,000 people to a fatal drug overdose. That's a big number, and big numbers tend to wash over small brains like mine. So I look for ways to make it more understandable. Here's a way. Do you all remember the shooting at the Orlando nightclub, the Pulse nightclub last year? 49 innocent people were slaughtered by a madman. Here's how I describe the problem. Imagine that Pulse nightclub shooting happening 3 times a day. Once in the morning, once in the afternoon, and once in the evening. And then imagine it happening for 365 days in a row. You don't have to do the math. I've done it for you. That's about the number who die from a fatal drug overdose. So you have to have hard conversations, and you have to find a way to make them understandable. Kids aren't going to listen to me. I'm too old. They may listen to you. You're younger and a lot smarter. But in the first instance, we have to get kids talking to kids. And then we have to tap in wherever we can, as relatives, as aunts and uncles, as grandparents, through their teachers, through faith-based institutions. This is not a government thing. Vivek said it right. This is a whole of America thing. And we're not doing a good enough job right now.
One thing, if I might add, Toby, about the role of parents, and I completely agree with what Chuck said. The parents have an incredibly powerful role they can play in moving our society forward on this issue for a few reasons. Number one, parents can help accelerate the culture change that we need that dictates how people think about addiction. Through the conversations you have, through the example you set, you can actually change how people look at addiction and shift folks from looking at it as a source of shame to recognizing that this is in fact a chronic illness. The second is parents can provide support for families that are struggling with addiction. I had a young mother I met on the road when I was traveling who told me that her neighbors were always there for her whenever her family ran into hard times. When her husband lost her job, when they had a relative who passed away unexpectedly, they were always there. But then her son overdosed from opioids and sadly died, and nobody came to visit. People didn't want to interact with her on the street. They didn't know what to say. They didn't want to draw more attention to what had happened for fear that they might embarrass the family, because after all, they believed, isn't this a shameful illness? But by demonstrating otherwise, by reaching out when these things happen in communities, parents can demonstrate a different way of treating addiction. And finally, parents are often our most effective advocates. We do need change in policy when it comes to addressing this epidemic. We need investment in prevention. We need expansion of treatment. We need Narcan made more available to first responders and families. We need changes that will make coverage more accessible to people, because coverage is, health insurance coverage is essential for people to get treatment. And I often tell folks, if you are serious about addressing the opioid crisis in America, you have to be serious about expanding coverage, because those two go hand in hand. And parents are powerful forces for helping push our elected leaders to understand that, to take measures to actually address this epidemic. And measures that might be hard, that might be politically controversial, but this is a time where we need moral leadership in our country on these issues more than ever before. And there are few voices that are stronger moral leaders than parents.
You all heard me talk earlier about Narcan, and there's a very nice project going on here led by the individuals at Metro Hospital about moving Narcan out and making it more available in multiple different locations. Have you seen this happen across the country?
I have. It's a good thing. It saves lives. I hate to oversimplify, but that's my view on it. You might be surprised to learn that the DEA has also trained 1,100 of its special agents on the use of Narcan and naloxone. Not because we are first responders, because typically we're not. Occasionally we are, but typically we're not. But because, as I mentioned earlier, it scares the hell out of me to think that one of our special agents might bump into this in an arrest or search warrant scenario. Just like the officer in East Liverpool, Ohio, it can be lethal to the touch. And so we're training on it. And Toby, we recently put out a roll call video for the 18,000 state and local law enforcement agencies in the United States all get to see it. Just warning their officers that you can't field test. You have to assume that what you're handling contains fentanyl if you don't know what you're handling. Because so far, I think, we haven't lost a first responder to an overdose, but I fear we will.
So let me, while we're on the topic of Narcan, there is a thing going on around the country right now called Narcan parties or Lazarus parties. You want to explain what that is?
Well, there are unfortunately several kinds of very concerning parties that are happening, and Narcan parties are one of them. And these are parties where people will bring Narcan to a party where there are opioid medications or heroin that's being used. And they'll essentially use Narcan as the rescue and push themselves really to the limit, essentially a near overdose, and then use Narcan to rescue themselves so they can get the maximal high. And this is obviously deeply concerning because, number one, you may not always catch people in time, but it is this approach is really fueling the further misuse of opioids with the understanding that there might be essentially a backdoor or a way out using Narcan. I have also sadly heard about parties where students, basically they're called pill parties. They all bring a bottle of pills from their parents' home, and they dump the pills into a bowl, mix them all up, and then they pass them around, and it's like Russian roulette, but with pills, and they each just take a handful and see what they get. And I was in one community where such a party had happened recently, and the parents told me that their son, in fact, came home after the party, late at night after they had gone to sleep, and then the next morning they were making breakfast and he didn't come down. And they went upstairs finally to check on him and make sure he was okay, and they found that he was unconscious. They called the police and they were able to fortunately revive him. He had in fact overdosed on opioids. And the police very smartly actually mapped out the other kids who had been at the party, recognizing that they could have been at risk as well. Went to their homes and found several more kids who in fact were unconscious because they had overdosed. These are incredibly concerning. And I have to believe that in some cases, the people who are going to these parties don't fully appreciate the risk that they're undertaking. But we also need parents to be aware that these are happening so that they can not only educate their kids, but be on the lookout for these types of parties.
Relatedly, if I may, Toby, we're seeing another strange phenomena. When we see a spike somewhere in the United States, Syracuse, Tampa, Topeka, wherever, of fatal overdoses, right? You would think rationally that people, addicts, users, would move away from those areas. Actually, they flock to them. They're chasing the high. That's the name of the movie we produced with the FBI. They're chasing the dragon. They want to walk that line because if someone died from it to an addict, that's good stuff. That's what they want. And it is really remarkable, and as I said, it's counterintuitive, the way an addict will move in the direction of death.
You know, there's been some stories in the press recently, and frankly, we've had some experience at the Cleveland Clinic with caregivers in the institution being found dead in men's room with overdoses. We've taken a rather bold step, and I'm very proud of the organization for doing it. We think that we do random drug testing for all employees now. We think that it's important because we don't want patients being taken care of by somebody who's high. We do similarly. We think that it is a disease amongst our caregivers, and we feel it's important that we take care of our caregivers. To the best of my knowledge, we're outside of the VA. We're about the only hospital in the country that does that. Some do it for anesthesia because anesthesiologists because they have a strong history of potential exposure and access to these drugs, and also a strong history of having high incidence of that. And I know that Massachusetts General did that, for the anesthesiologists. We're doing it across the. We're in fact, frankly, just to show you, I was called for my random drug testing. By the way, that's not why I'm leaving. Just to set that. Just so I thought to set the record straight. Do you recommend that for other organizations?
Well, I think it's, first of all, I want to commend you on holding yourself to a high standard. I think that we absolutely can and should, as healthcare institutions, hold ourselves to high standards and be models for what we want to happen out in the larger community. I also think that it's important that we do this in a compassionate and thoughtful way, recognizing that the people in the healthcare professions are often under a great deal of stress themselves. Burnout rates are incredibly high. Suicide rates in the healthcare professions are incredibly high. And in our society, there are sometimes unhealthy ways that people turn to deal with stress, and sometimes socially acceptable ways. Some people will drown themselves in their work to deal with stress, and that's seen as socially acceptable, even though it's not always healthy. Others will drink alcohol. Others will use drugs. So I think we have to recognize that there's a lot of stress within our own profession, and we need to think about how we deal with that. So, I mean, the approach of screening and then connecting people to help, I think is an approach that that I can appreciate because that's ultimately what I think part of what we need to do. Now, there might be different approaches that different institutions want to take around this, but I think that the bottom line is that we have to model the kind of behavior that we want to see out in the community, and we should do that unapologetically, boldly, and we should be proud when we're able to hit that standard, because we show other institutions that it's possible.
Thoughts, Chuck?
I hate going after him because he's so articulate, but I completely agree. We've been doing random drug testing in the federal government for as long. I started years ago as a federal prosecutor. Whether it's the fear of getting caught or the enforcement of societal norms within the law enforcement community, or some other reason, it seems to work. And I agree, you're holding yourselves and your employees to a very high standard. You should. You're the Cleveland Clinic, after all.
So I've got two more questions that I want to ask, and then we're going to open this up for questions from the audience to come down here in front to the microphone. There's a lot of discussion about marijuana. And when I talk to my physicians who are experts in that field, they feel that marijuana is a gateway drug. Thoughts?
I'll go after you again.
Well, I think, so a couple thoughts on marijuana. Number one, I do think that people underestimate the risks associated with marijuana. I run into young people all the time who say marijuana is not addictive. Turns out it actually is. And what we know that with young people in particular, that the developing brain is particularly vulnerable to developing substance use disorders and addiction. And when you develop a substance use disorder at a young age, it actually increases the likelihood of you developing an addiction to other substances. So in that sense, addiction to marijuana or any substance, including nicotine, during adolescence and young adulthood when the brain is developing, is in fact very concerning. I do think just more broadly about marijuana that I worry that we have gotten away from allowing science to drive our policy when it comes to marijuana. But we have, particularly among state legislatures, have often gotten caught up in momentum and have passed policies around recreational and medical marijuana that aren't always supported by what we know scientifically. Now, should we be researching medical marijuana to look for potential therapeutic uses? Absolutely yes. Should we be working hard to reduce the administrative and other barriers to doing that research in the government? 100%. But what we should not do, I think, is make policy that's based on guesswork, because when we do that, then we just put people at risk.
You know, I always thought it was interesting that marijuana will probably be the only drug to come on the market that hasn't gone through the FDA.
So we make the scheduling decision at the DEA about into which schedule marijuana is placed. But to Vivek's point, we are closely tethered to the science of the FDA, who makes a recommendation to us. In fact, it's, without getting overly detailed, it's essentially binding on us. Marijuana is not medicine. There is a sort of a strict definition of medicine that I employ. Number one, it's something that's measured and studied by clinicians and physicians and statisticians and epidemiologists. We know how to dose it. We know what its side effects are. We know a whole bunch of science about medicine. Smoking marijuana, you don't have none of those things pertain. As I tell people, it's somewhat glib, but you don't smoke Claritin for seasonal allergy relief. It's not the way we take medicine in this country. What we do at the DEA, which may surprise you, is we permit people to register with us to study the effects of marijuana and its constituent parts on the human body. Believe it or not, we have about 500 people registered with us. We permit studies on smoked marijuana, which may surprise you. We even permit studies on smoked marijuana on human subjects, which may surprise you even more. Because if I'm going to insist that I be tethered to the science, then I must let science progress. If it turns out that there's something in smoked marijuana that helps people, that's awesome. I will be the last person to stand in the way of that. And as you both know, and I'm sure many people in this audience know, there are constituent parts of marijuana, such as CBD, that are proving is not the right word, but appear promising for the treatment of certain illnesses, including childhood epilepsy. Again, that would be awesome, but let's run it through the FDA process and let's stick to the science on it.
Okay, while you all are coming down here to the microphone, I got one more thing that I'd like to have you do. First of all, what's the one thing that you'd like people to come away from this discussion with that they could begin to influence this epidemic across the country? Chuck?
That the DEA is incredibly cool.
And handsome all.
I want them to leave with a couple of things. One is that the men and women of DEA do unbelievably difficult and dangerous work, and that we make our communities safer. But the point I want to underscore here is that we're not going to do it without you, and we're not going to change the culture unless you help us change the culture. And as Vivek outlined, right, as I tried to outline, we have to change the culture through education, through treatment, through rehabilitation. We're not going to enforce our way out of it. You play a role in this. It's not a hands-off thing. We've changed the culture in the United States in ways that might seem benign. Seatbelt use. In ways that are less benign. Teenage smoking. We can change the culture. You've got to be a part of this. That's what I want to leave with.
Vivek?
Well, first of all, I'm just so glad that we are doing this, and I want to thank Toby and the Cleveland Clinic for putting it together, and it's a real honor to be here with Chuck as well, and thank you for your leadership at DEA. The main thing I would love for you to remember when you leave here is that the opioid crisis is one of our most critical public health challenges, but it is also a surmountable challenge. And it is the things that you do in your everyday life that can actually help us beat this crisis. That means how you talk about addiction with your friends and family can make a big difference in whether somebody feels that they have the ability to open up and seek help or get support. How you choose to speak up for people in your community about the needs that they have when you're talking to your state legislators or to other leaders can make a difference in whether we pass policies that ultimately help people. And how you set an example in terms of how you live your life and how you avoid dealing with stress by using unhealthy approaches like substance use or like using alcohol as a tool for dealing with chronic stress, that can also have a powerful impact on your children and on the people around you. So I don't want anyone to leave here thinking that this is a government problem to solve, that it can only be solved by big institutions. The most powerful steps that we have taken historically to address public challenges have often involved individuals and the decisions that they made, the conversations that they had, the culture that they changed. That's what happened with smoking. In 1964, the Surgeon General's report on tobacco was issued, a seminal report which made the link between smoking and cancer. And many people credit that report with kicking off a half-century's worth of work on smoking that reduced smoking rates from 42% in 1964 to near 15% today. But that report in and of itself didn't change lives. What changed lives and changed this country was the response to that report, the fact that mothers and fathers and teachers and administrators and business leaders all across the country decided to help change views and attitudes around smoking and lead by example. Our report that we issued in 2016 on substance use and addiction was the first ever Surgeon General's report on the topic, but that report in and of itself won't change the country. What will change the country is your response to it. Right. So I want you to remember that when you leave here.
Great. Question?
Hi, thanks for taking my question. You talked a little bit about this, but I wonder if you could talk more about the effect that addiction and overdose deaths has on family structures.
That's such a good question. I was just reading earlier today, in fact, about the increased number of young children who now have no parents and are in orphanages and in other government service centers because their parents have passed away from overdose deaths. This is unfortunately something that we're seeing in many parts of the country. We have more grandparents who are taking care of their grandkids because their children their grandkids' parents are either dead because of overdose, an overdose situation, or unable to care for their children because of their struggles with addiction. So this is actually having a significant impact on family structure, on the experience and the upbringing of our children. So this is not just a problem for today, but it has real material impact on the next generation.
Thank you.
Yes.
Being a wellness person, I like to think about what is the root cause of the problem. And I'm wondering from a biochemical perspective, how do you feel that we can use a lot of the tools that we have today, such as DNA? Some people can take an opioid and they're fine, and another person can be addicted on their first dose. So where do you see that going, and is there a role that we can play in being more preventive and empowering people more with knowledge?
It's a good question. You know, there is, one of the things we detailed in our report was actually the various factors that contribute to someone's risk. And we know that somewhere in the range of 40% of your risk for addiction is linked to genetic factors that you may be born with. And the rest has to do with your environment, you know, and other factors. There may be advances over time that enable us to identify people who are more at risk. And perhaps we can then adjust our prescribing behavior accordingly and other practices accordingly. But I will say that for everyone, what's important is for us also to realize that there are certain key building blocks in people's lives which help protect them from substance use and addiction and from a range of chronic illness. And this is linked, in fact, to emotional well-being. The ways in which we deal with stress have a powerful impact on our risk for illness. And right now, we don't actually think about emotional well-being as an important pillar of prevention. Some of us do, but not enough of us. We think about nutrition, we think about physical activity, but emotional well-being, it turns out, is just as important when it comes to determining our health. So our investment in understanding emotional well-being and recognizing that science actually tells us that there are tools we can use to cultivate emotional well-being and to enhance prevention and health, our ability to do that, to understand that science, to put it into practice in programs, is going to help us, I believe, in the long term, address our addiction crisis as well.
Great.
Yes, thank you.
Yes, ma'am.
Hi, I'm Dr. Carol Cunningham, the State Medical Director for the Ohio Department of Public Safety. Our Governor's Cabinet Action Team that I sit on has actually done a lot of the things that you've mentioned in terms of prescribing. And I'm so glad that you mentioned the fact that it's opioids and not just heroin and fentanyl. Our death rate in Ohio for opioids has exceeded our deaths from traffic accidents. One of the challenges that remains is the huge increase in opioid use in the rural areas. And our second challenge is the cost of naloxone. We've expanded it to law enforcement, obviously, but for lay people and families, particularly in those rural areas, I almost feel like the federal government does have an avenue to try and reduce the costs. The Evzio that was on the market was $400. Now it's $1,500. Naloxone, we negotiated a price for $40 per dose, but for a volunteer EMS agency in a rural area that may have to give 6 doses or 10 doses on one patient, that exceeds their budget. So I'm wondering about solutions or ideas for solutions that you may have for that, as well as to increase the access for the rehabilitation services in rural areas where their only source may not be the Cleveland Clinic, it may be, a critical access hospital.
Well, there are a few thoughts I have for you. No great solutions. I mean, the drug pricing issue is sadly an issue many states are facing, and specifically with not just the price of Narcan, but, for example, the price of Vivitrol, which is one of the treatments that's part of the medication-assisted treatment armamentarium. I actually think that this is a place where government can and should use its power, its market power, to work with the pharmaceutical companies to get more affordable prices for these medications, because literally there are lives at stake, and we already know that states and localities are often underfunded with their public health budgets, and so they don't have unlimited amounts of cash to purchase Narcan. But, you mentioned rural areas and how they're struggling. I do think that we could also do a much better job across the country in utilizing telemedicine to provide some of the counseling and support services that must be part of addiction treatment and recovery. And finally, it's worth noting that addiction, in so many ways, is a disease of despair that's driven by a deficit of hope. And as I traveled around to rural areas in particular, I often find people would often tell me that their lives, they felt, not everywhere. There are many people who in rural areas who had very fulfilling lives, but there are many rural areas that are struggling, especially with the economy where it is, who weren't able to make it through the economic transition and are struggling to find jobs, who are having challenges in healthcare as well, because the healthcare infrastructure hasn't fully percolated to them as well. There are a lot of struggles that folks in rural areas face that people in urban areas don't. And it's in that way that jobs are in fact connected, I believe, to addiction. And if part of what we want to do is ensure that we're reducing addiction from a preventive standpoint, we have to think about how do we bring more hope into people's lives. And having a good, well-paying job where you can take care of your family, you can provide for your children and make sure they have a good future, that's an important part of hope for any parent out there. And we got to think about that as part of the larger picture.
One sad footnote to add with respect to rural areas, we see time and time again that drug gangs know that if they hook people in underserved areas, in areas that are far from a rehab center, or areas where folks can't afford treatment or rehab, then they have a customer for life, which, by the way, may be a relatively short period of time. And we see drug gangs actually giving out free heroin as loss leaders in some rural areas. If you want to talk about how pernicious and vile some of these drug gangs are, think about that.
Thanks so much to the Cleveland Clinic for doing all of the work you've done, and thank you both for coming back to Ohio.
So why don't you identify yourself first and tell you how you got involved in this?
So my name is Steve Dettelbach, and I used to be the U.S. Attorney here and worked a lot, obviously, and I witnessed some moral leadership of the Cleveland Clinic on this issue. You talked about changing culture. I just want to ask a question about maybe one small part of that. When I was a child and people went to the hospital, the vital signs were things like pulse and temperature and blood pressure. And somewhere along the line, a different vital sign got added, which is relating to pain. I was wondering if you could comment on your opinion as to, first of all, tell us when that got added, and then comment on your opinion as to whether it's possibly time to revisit that decision as to whether pain should be a vital sign on the same level of importance as somebody's temperature or blood pressure.
Before you answer, just let me say that Mr. Dettelbach and Carol Randone both led the activities here in Cleveland to begin to deal with this issue, and I think they deserve a lot of credit for bringing this initially to our attention.
I can tell you as a before Vivek answers the technical part of your question, as a former federal prosecutor, both Steve and Carol are leaders in our U.S. attorney community and widely admired for their intellect, their integrity, and their ability. You have the real deal here.
Yes, we do.
Yeah.
It's great to hear. Well, first, thank you for all your service here in Ohio. The pain scores you mentioned are a source of common questions and discussion when we travel. I think the problem is not our assessing pain aggressively. I think the challenge is in how we respond to that. And part of the issue that we had was we would assess pain and then set a goal of achieving zero pain, and opioids became our most effective tool to eliminate pain entirely. And therein lay some of the problem. Which is that there are some circumstances where eliminating pain entirely may not be our most important objective. While we do want to reduce suffering, we also want to pay attention to safety as well. And so part of, I believe, the challenge was not just in having a pain scale, but it was not in not training people how to use that pain scale appropriately and wisely. So do I think we should get rid of the pain scale entirely? No, I think it's important for us to assess pain, but I think that we have to set realistic goals around managing pain with our patients. We have to train our providers in how to do that. And we really need to find safer ways, really, of addressing pain. Opioids, while they're remarkably effective at reducing pain, their safety profile leaves a lot to be desired. We've been talking about physical therapy and cognitive behavioral therapy as being important tools that are underutilized, but they're often not as easily accessible for people, partially because of time and partially because of insurance coverage. But this is also where I believe we have a lot of room to go in investing in research to find safer, non-opiate alternatives to pain. Some of that work is already being done now by NIH, but to me, those are worthwhile investments to make.
Good. We got time for just a couple more and quick ones.
Thank you so much for being here and for making this a community discussion. You touched on this earlier, Dr. Murthy, when you were talking about funding for rural areas and job creation, but I was wondering if there are other identified factors that help explain the geographic distribution of this national epidemic. So, for example, why Ohio and why not Virginia?
That's a good question. We were actually just chatting about that before the session, Toby, Chuck, and I. You know, I think while there are theories, I don't think we really 100% know why the epidemic has popped up in the places that it has. Can we connect it in some cases to poverty? Yes, but there are many places that are struggling with poverty in our country. You know, can we try to find some sort of urban or rural pattern? That's not always consistent. What we do know is it's been a confluence of factors, including prescribing patterns, lack of treatment, unfortunate stigma associated with the illness that have combined to produce the crisis as it is. And so, you know, while we don't know exactly how we got here, I do think that we have a pretty good sense of how we can get out of the crisis. And that's what and our challenge now is how to implement that, how to sustain that, and how to fund those interventions, you know, for the long term.
Chuck, I think it's worthwhile to have repeating the discussion that you and I had about the age distribution of addiction.
Right. So I had mentioned earlier that it cuts across all demographics by race and gender, but also by age. And I was surprised when I saw just today the recently released statistics from the Cuyahoga County Medical Examiner's Office. We think of this, putting aside race and gender, as a problem of the young. And actually, as we discussed earlier, the midpoint, the median age for fatal drug overdoses in Cuyahoga County is 35. And I believe about a third of the fatalities are those between the ages of 40 and 60. So I don't know that I either have a good answer to your good question, but it cuts across all demographics, and that's what's so frightening. This is touching every corner of our country.
Yes, ma'am.
You've both mentioned the importance of partnerships and changing culture. And so my question is primarily for Mr. Rosenberg. I'd like to know how you see the culture changing in law enforcement to embrace the understanding of addiction as a chronic illness as opposed to moral failing or criminal failing.
Right. For one thing, I think maybe 10 years ago, I wouldn't have been sitting here. Either I would not have been invited or I would not have accepted. And I think it's partly a function that all of us as we age or as we get more experience, I don't mean individually, I mean institutionally, realize that the problems that we once thought were simple are really quite complex. I know as I get older, I see more gray than I see black and white. I'm hearing this from chiefs around the country because I interact with them a lot. In many ways, our chiefs, our sheriffs, get there before we do. And they deserve a lot of credit for bringing this issue to the fore among law enforcement. But I go to conference after conference where we are now sitting with, talking to, sharing stories with doctors, physician's assistants, folks in rehab, folks in treatment. We literally were not doing that 10 years ago. So maybe 10 years from now we'll be better still, I hope. But we have to change our culture too. It may have surprised you to hear me say that I think of addiction as a part of a public health crisis. It may have surprised you to hear that we don't take our limited resources and direct it at the bottom of the chain at users, but rather try to go up the chain to the very violent cartels and street gangs. That's part of a culture change. If I'm going to ask you to change your culture, you should certainly expect that I will change mine.
Last question.
First, I want to say that I did invite Senator Portman to the discussion tonight. I hope somebody from his office is here. I thought this was important to get accomplished. Dr. Murthy, secondly, I just wanted to thank you for being the Surgeon General. Without being too negative, I still wish you were the Surgeon General. Leave it at that. So, briefly, without being too long here, I'm a nurse anesthetist. I'm very passionate about this. I see my patients all the time struggle with this illness. What I have seen in my research is that this is actually a mental health issue and it is a depression issue. I'm concerned that our leaders are going about this the wrong way by attacking it being a prescription overdose, over-prescribing medications. I think that is an arm of the problem, but I think what we need to look at is why these kids, mainly adolescents, are using it in the first place. What I have found in my research is that, I don't know if are you familiar with Project Self-Discovery with Iceland, the work that they're doing in Iceland?
No,
Okay.
I'm not.
Essentially what Iceland did is they used to have the same problem we had.
Excuse me, if you got a question.
My quick question will be then, is what I have found is school lunch shaming in different areas of our country are actually attributed to a higher opioid epidemic. Meaning, when cafeteria workers are stamping kids on their arms and saying, you don't have money for your school lunch, we're going to let it be known that there's an issue. And what I've been finding is these communities have the highest rates of the opioid epidemic there. So my concern is maybe there's some other things going on in those communities that is attributed to this epidemic. Would you agree with that statement?
Well, I think you bring up a really insightful point. What's your name, sir?
Scott Schulte.
Scott, okay. Well, thank you, Scott, for that question. We talk a lot about the physical pain that's driving the opioid epidemic. We don't talk enough about the emotional pain that's driving it. If you actually look at the circuitry in the brain, the pathways for emotional pain and for physical pain, in fact, overlap. And anyone who's cared for patients with pain knows that emotional factors can, in fact, influence your physical experience of pain as well. And so if we want to really think about the root cause of what is driving this epidemic, we have to also consider, among those root causes, people's emotional well-being and the fact that there are a lot of people in our country in emotional pain. And there are many reasons for that. You mentioned kids who are shamed in school because they need assistance for lunch or for reduced breakfast. And that is a real problem. One of my most heartwarming conversations I had when I was Surgeon General was with high school students in South Florida who had started a program called We Dine Together, where they were bringing young students who would often eat alone together at lunchtime so they could connect with each other, support each other, and so kids wouldn't feel alone. We live in the most connected age in the history of civilization. We have more ways to connect via technology than ever before. But 20% of adults in the 1980s said that they were lonely, and that number has now jumped to 40%. Why is that? We know that loneliness is in fact deadly, that loneliness is associated with shorter lifespans, and the reduction in mortality, the reduction in lifespan from loneliness is comparable to the effects of smoking or obesity. So as we start to think about the sources of chronic stress and emotional pain in people's lives, whether it's loneliness, whether it's violence, whether it's bullying or shaming, whether it's poverty or discrimination, we have to understand that these are all part of what is driving this overall epidemic. which is why I think we as a country have to make emotional well-being a priority, not just something we think about when it's convenient, but a priority because it drives the health outcomes that we ultimately care about.
Well, this has been an absolutely terrific opportunity to explore in some depth a very difficult social and problem for our society. And this is going to be part of our continuing community healthcare forum. The next one of these is going to be on October 17th here at the Global Center, and we're going to talk about transforming healthcare in America. I invite you to come back. And I'd like to have you join me and outside for a reception, and then join me particularly in thanking Mr. Rosenberg and Dr. Murthy on the time that they've spent with us and the fact that they're leading this very important endeavor. So thank you very much, both of you. Thank you. Terrific. Thank you. I can't thank you enough. You guys are great.